I think this is the big advantage of these ceramic on ceramic devices. No? Some papers I would like to show, this one about bearing surfaces, and we know that the cross-link liners and health, they have good behavior with the wear, but they have poor oxidation resistance. On the other side, the remelted cross-link polyethylene has less fatigue resistance. So the cross-link process, we know that increases the wear properties, but maybe they are to be at more risk of fracture. So we don't know what will happen at 20, 25, or 30 years with these liners. No? Another study that shows that really these modern devices has less risk of fracture, but there is some situations that we have to take in care in order to avoid some complications. The last one I show you is that these ceramic on ceramic wears wearings decrease the wear, but still now there are some concerns about these ceramics, especially the fracture and the squeaking of the hip. Some cases treated during these years with these devices, a young boy with these dysplasias, with these both hips and ceramic on ceramic, he's still playing football. I don't recommend this, but he's still playing football with his friends. Another very young patient after some surgeries in another hospital because of Pérez disease. Finally, we decided a total hip arthroplasty. He's still climbing. I don't recommend it, but he does. And this is another case with a young lady after an osteotomy, a periacetabular osteotomy, and she is still dancing. But what about the concerns? We know that there are two main concerns with these devices. The first one is the noises. There are in literature many nouns about these noises. And of course, the insert of the head or the insert. Well, let me to show you one case about the noises. This is a young woman with, after this varus femoral osteotomia in the years, I replaced the left hip and she reported me some squeaking in his hip. After a few months, I replaced the other hip and the squeaking of the left hip disappeared. The reason, I don't know, because we don't know the real etiology of these noises. No? What about the fracture? I haven't had any fracture during my last 20 years until last year. This was my first fracture of the insert. When the patient arrived, we reviewed the previous X-rays, and we saw that probably the insert was not very well positioned, and maybe this was the cause of the fracture. During the surgery, we removed all the big fractures, and we replaced the insert for another ceramic insert. Unfortunately, problems never arrive alone, and only a few months later, I received another patient, similar patient, with this fracture. And when we reviewed, we saw that the surgeon didn't position very well the insert. So in both cases, the problem was the same, a technical mistake made by the surgeon. During the surgery, you can see the fracture, and we replace again with another insert of ceramic. If you use ceramic and you have a fracture, it's very, very important. You must know that you must use another ceramic or ceramic on poly. Never, never, never metal on poly. Remember that, please. Finally, I want to show you that this idea is not new. There are some reports with long follow-up with very young patients with these ceramic on ceramic devices. So take-home message for me is that ceramic on ceramic has the lower wear rate up to now. We had very good results after 20 years, and literature shows the same results. But remember that this is a very demanding and precise technique. A bad technique is very, very dangerous because the main problem will be the fracture of the insert or the fracture of the head. It's very, very important, the patient selection. if very big patient with a high body mass, with a very high weight, or with a very active activities, maybe it's better ceramic on poly. And for me, up to now, this is the best for young patients. The future, I think that maybe for young patients, this will be the future. No, there are some trials up to now, especially in England and Australia, with these devices. And as they ask, maybe this is the new gold standard for very young patients. So thank you very much for your attention.
Thank you, Dr. Miquel. Now it's turn Dr. Erwin Cab, total hip arthroplasty in juvenile arthritis.
Thank you. Good morning. It's a wonderful stay here. Okay, sorry. Again, good morning. It's a wonderful stay here. Thank you, Rafa, Dr. Vicas. Thank you, Nicolás, by this great opportunity. First time speaking English. It's very good for me. I am Dr. Erwin Cab. I come from Mexico, Mérida, Yucatán, a great place, an ancient culture. This is my introduction. I don't have any kind of interest conflict. Okay. I want to begin this speech with that article. It's very interesting, all the speak there, because the AR, rheumatic arthritis, it's a very common and a frequently disease. In that moment, was a register from 1995 and 2010. You can see all percentage or increase in that severity disease. This is a form or the CD4 cells introducing into the wall of the principal cells and cause of the destruction between each other, CD8 cells and CD4 cells. In this graphic, you can see the principal causes of the hospitalizations in that kind of patients. This information is from ORC. It's very interesting because we don't understand all the principles, reasons for these attentions. This graphic shows you the hospitalization that include arthritis and other rheumatic condition. In this time, I want to talk to you about the ankylosing spondylitis. It's a very interesting disease, and all is a big difficult to work with these patients. Distribution for hospitalization, for arthritis and other rheumatic conditions. Okay, you can see all the percentage. And distribution for conditions among adults and between 18 and older. It's a problem, the differentiation between AR in young patients for the age groups, because the child is in another condition. Since 2022, the ACAS and the American College of Rheumatology, we recommended this kind of measures from the treatments, and the best moment in that patients will be operated. In 2023, the same thing, the ACAS and the Rheumatological College from USA emit that kinds of recommendations. The optical timing, this is very difficult because if you see one patient with AR with mobile joint, or if you see a young patient with no mobile joint. Okay. This work is very interesting. Why? Because the primary total hip arthroplasty in patients with ankylosing spondylitis. It's a very different condition from AR. It's a totally condition in the aspects for your diagnosis on these patients. You can observe the incidence, it's increased in that kind of patients in that moment of the time. Okay. In this hospital, I worked 11 years ago. It's very difficult for us to obtain all the resources for that kind of patients because the people not gives enough resources for this kind of surgery. We depend in that hospital for the government help and their patients themselves. Okay. All the patients in this work confirm the diagnosis with antigen HLA-B27. This is a fundamental blood test for the diagnosis, the clinical aspects, and the blood test with this kind of antigen. In the autoimmune rheumatic disease, this antigen had two arms, long arm and short arm. The principle for the diagnosis is the short arm. With short arm, you determine the precisely diagnosis from spondylitis, ankylosing spondylitis. Case 1. Male, 20 years old, diagnosis, spondylitis, ankylosing spondylitis, hip mobile, incipient phase. It's the principle, the start. You look all the changes and the quality of bone. It's like ancient people, but this patient has 19 years old. It's very interesting, all the changes around the hip. That was the solution with total hip replacement. We work with uncemented-less stem and hip cups. Was impressed fit because the quality of the acetabulum stock was good. Case 2, male, 27 years old, left hip mobile. You can see all the space, it's very short. The quality of bone. In this case, we use a cup with screws and uncemented-less stem. Male, 21 years old, both hips. This is an extreme case. Total fusion, patient no mobile, both hips. First was the right side, and second time the left side. A difference 8-9 years. Male, 20 years old, left incipient, hip mobile. Mobile, it refers to range of motions, a little range of motions. underthink and flexion. This is resolution. The same thing with a fixation of the cup with the screws. That was my team in that time. And to take home, please read this article. It's very interesting with all the changes for the adequate many forms to work with these kinds of patients. Thanks a lot.
Thank you, Dr. Erwin. Good presentation. Now, please, Dr. Sacha Bittelman. Total hip arthroplasty in hemophilic patients.
Thank you very much for all the people from the SICOT to give me this invitation to talk about the very unrare disease to have a total hip and total knee replacement. And I expand a little bit my talk in knee because it's very, very more common than a hip in hemophilic. And why young people? We're not talking about adolescents. We're talking about people around 20 to 30 years because this disease needs a longer time to produce a problem. Because we're doing a lot of very elderly people with a very good results, and we're introducing more and more elderly people, we started to find these results are very good. And this is a reason because we started to do this with very special kind of patient. The demography changed a long time ago. On my first experience, less than 20 to 30% of our surgeries were people less than 65 years old. Now it's almost half and half. Maybe 40% of my patients got less than 40 years. And this patient need or ask to have a very good results and very quick. They need to work, they need to play sports, and they need to have these surgeries to be done now. And this is the first question they ask to you. I got a lot of pain, I can walk, and I need no pain anymore, and I need to play all my sports, and I need to carry on doing my job with a normal hip or a normal knee. This is a main problem we got with young patients. The life expectation is higher than the patient with 65, and they walk more, they do more things, and the wear of these joints is going to be quickly. The changing of demography is because there's too many pathologies who 30 years ago we didn't take care about as an election for a total hip or total knee replacement, and we're introducing now this in our clinics. This is a pathology. The joints more involved are knees far away and ankle, elbows, and hips. Very rare other one. What happened with the pathology? There is a chronic hemophilic arthropathy who involves this, a bleeding recurrent synovial who is very bad, and this is going to destroy the cartilage. What happened, why we do the indication for total hips or total knee and no other kind of treatment is because we got advanced degenerative changes, the pain, of course, but deformities, and always they started to have stiffness. To have good results, you are good surgeons, but that is not enough. We are only a change in this part of the treatment. You must work with a very specific hemophilic treatment center. Hematologists, nurses, physiotherapists, and a lot of people. You are only one more of this team. They are going to do all these things for you. You can study this. Somebody's going to ask you about these things, but you don't need to be an expert because there is somebody else who is going to work with you about what is going to be able to put this patient in theater. Some question we always ask What happened with the prophylaxis on deep vein thrombosis in these patients? Good question. I don't have the answer. We didn't use it in anyone, and we don't find any DVT in our patients. What we need to do, we try to do at least 2 procedures in the same surgery because it's so expensive to bring one of these patients in theater with all the things we need to introduce in the treatment to control the hemophilia. Risks are high. It's more frequent to have infections, and you need to consider this, especially in the patient who got HIV positive. Bleeding acute in this patient, very, very rare. I didn't see anyone. And if you got something like this clinically, you must check what is happening. And normally what is going on is the patient got an infection, an hematoma, or who is going to be infected, and you need to treat it like that. Our experience is 37 patients. This way, I say to you, we work for a group, for a center on hemophilic, and this is changing for several places in my country. At that time, we did 65 surgeries, only 8 hips and 48 knees. Always we try to do a couple of these in the same patient. All the patients are under 35 years old, and I think the younger was 17 or 18, no more than that. Few patients like this one was very, very quick, the degenerative changes, but this is a very straightforward procedure. When it's in theater, the patient is compensated for the hemophilia. You forgot this patient got an hemophilia, and we entered to the surgery. There's a lot of fibrosis and synovia you need to remove, but the procedure is like a normal one. This is a very unlucky patient who got dysplasia and hemophilia at the same time. But again, was no any difference to do a total hip in the left side and a total knee in the opposite side at the same surgery. This is the kind of stiffness we got. I'm going to show you a video of this same patient, preoperatively and postoperative, but you can see we can straighten the knee, we can flex it at all, and he got some problem on the opposite hip as well. This is a kind of surgery you use a knife just for the skin. All the surgery is done by hammer and a chisel. And this is a result. You can see, doesn't look very good. You can question about the alignment and everything, but the patient is so happy. This is a knee we got normally, a stiff knee. This is what is looking inside, very bad synovia. You can see there is no collateral ligament, no collateral ligament in the other side. You end, of course, with a very constrained prosthesis. And this is the result. You can see the patient can flex a lot. And this is an X-ray follow-up. Another one, few patients who got fracture as well. You can see these are young men normally. They like to do a sport and everything. And they got fracture as well. And we try to do primary prosthesis always, but several times we need to use this more constraint. Always the synovia is there. We produce a lot of problem, but if behind the synovia, your ligaments are intact, we try to do a primary prosthesis. This is a patient from the beginning I showed to you. He was an agriculture worker, still doing his job with that. And this is a result after 3 months with 2 knees. And you can see how is the gait, because need to be done the total hip on the left side. I don't recommend this. We tried to do sequentially in the same act, but we did with 2 teams at the same time. Our scrub nurse was crazy because we were asking for the motor and the drill and this other. I don't think this is a good idea, but we did several times. Our results were 3 patients who were infected, only 2 were deep, and we must do a revision for those. Only 1 non-infected hematoma. 5 patients get an arthropfibrosis, never had a fracture, and never has a loosening so far. Satisfaction, these patients are very satisfied. Doesn't matter how much they move, but they are very, very happy. Complex surgeries, yes, sir. Complex patient, I can tell you that. And all the people who are around, the patients with hemophilia are complex. It's very expensive to bring a patient to a theater, and this is a reason because we do at least 2 procedures. The orthopedic cost is the less one. A higher percentage of infection, but not that bad. But the good thing, they got excellent results and the patients are very happy. And for this, you got only one message. You must work with a team who can manage this. Thank you very much.
Thank you, Dr. Sacha. Now, please welcome Dr. Nicolás Restrepo, total hip arthroplasty in the high hip dislocation.
Thank you, Zule. It's a pleasure to be here in Cartagena and to chair this conjoint meeting with SICOT. We're going to talk about total hip arthroplasty in high dysplasia. We don't have any conflict of interest. And it's a difficult topic because it's a big challenge in adolescents to decide if we prefer to do arthroplasty. And in some cases, probably in most of the countries in the world, this decision is not by us, but the orthopedic surgeons should prefer to do the surgery and a hip open reductions. What happens with this open reduction and osteotomy? They think that it's a good mean to prepare the hip for a total hip arthroplasty to correct the length discrepancy, avoiding complications like sciatic neuropraxia, and have to do osteotomies to put our hip arthroplasty. But sometimes it would be difficult. It's difficult to perform. It's difficult even to maintain a proper reduction. So we have to put some wires occasionally. And even we have to do in 2 stages. So that's the rapid progressions to osteoarthritis problems. And the possible future disadvantage will be to deal with these scars and we deal with the fibrous tissue around our hip. It will be difficult, and even if it's bad reduced and don't have a successful surgery, deal with a new dislocation plus the previous surgery. That makes difficult to perform a total hip arthroplasty. The hardware removal probably have to deal with another type of stems that you don't use it, like short stems. And in femoral deformities, if you perform a varus osteotomy to reduce these hips, it will be difficult to set a proper total hip arthroplasty. What the literature say, there's not much to talk about this, but in this paper with prior pelvic osteotomy affect the outcome for sure. He compared the outcomes with and without osteotomy, and we need more supplemental screws, more autologous bone grafting. It's a longer mean operative times with more bleeding and more reoperations. What about total hip arthroplasty in the adolescents? We have to deal with these kind of problems. Bone is immature. Even the growing feces, the bone and the joint are growing up. And we have to ask how soon we perform this total hip arthroplasty, which osteotomy, which type of implant. All my preceding speakers talk about this. This paper talk about people with total hip arthroplasty in patients before 20 years old and younger. Historically, bad results. We tried 91 primary total hip arthroplasty in 78 patients, less than 20 years. In 1980 to 2016, average 17 years, with an average follow-up of 8 years with the Harris-Hip score of 92, and a survivorship and reparation at 10 years, 95%, and revisions for any case, 97.2%. And this paper is a systematic literature review talking about that is generally avoided, but now show improved functional outcomes with lower revision rates. After 98, the cut line, what's difficult and more revisions problems with the prosthesis, with the liner loosenings, as Miquel told us. Right now, with the cross-link poly and the ceramic on ceramic, probably there's problems are avoiding. So finally, we can have 3 scenarios dealing a patient, an adolescent, and a young patient, 3 scenarios with these dysplasias. The first one and the easy one is a well-reduced hip. The osteoarthritis is progressive, and we need to do a replacement. Like in these cases, for sure, the destruction will progress even rapidly, and we have to perform an total hip arthroplasty. The never treated that came to us to decide if we perform total hip arthroplasty, and the bad reduced with Harvard, probably the worst of the scenarios. What happened with the first scenario? In a well-reduced that the arthritis is progressive, it's the easy one. You have to perform as a simple primary, deciding probably the cup according to the morphology, the size, the walls. I'm according to Dr. Miquel Pons to try to do ceramic on ceramic in special patients, setting well the ceramic or ceramic on poly about the tribology. We have to deal with short and narrow stems. In this case, you have to be prepared to use short stems or stems, conical stems like this one. I put a pencil to see the narrow of these tiny stems. And in a well-reduced arthritic, you can choose the stem that you want according to the configurations of the stem, according to Dor. In the never treated, you have to take in account anatomical deformities. I always talk that the posterior wall have probably a good posterior wall and a bad anterior wall. So we need to resect probably a little bit of the posterior wall to get better coverage of our cups. It's different if it's crowd 2, 3, or 4, for sure. It's different, and we need to decide how to deal with the acetabulum. In this case, for example, it's a crowd 2. You have to resect more in posterior part to have a good descent of the cup. This crowd 3, for example, it's easy to use the border between the original and the false acetabulum to get more fixation in this part. And in this crowd 4, probably it will be difficult. Probably you need to descend it and descend to the original side. But always my recommendation is not to use a high hip center. It's better to use and localize the original part of the acetabulum to get a good fixation for a long time. Like this case, don't matter what do you prefer to use as a stem. And in the never treated patient, it's difficult to descend. You have to be careful with the descent. And for example, in this case, you for sure cannot descend even doing big traction. So that's the time to do an osteotomy, and don't hesitate to do an osteotomy, whatever you like, if you prefer, according to the doors type of the femur, subtrochanteric power lining tap or distal, it's better if you can descend more than 1.5 or 2 centimeters to do an osteotomy. The worst case scenario, the bad reduced hardware, it's important to remove it first. I applied the rule of 45 minutes and my destruction capacity of this hip. In this case, if you need more than 45 minutes to descend it, probably it's better to do it in 2 stages and wait more than 3 months to begin the other procedure and put the place. In this case, for example, we need a board to remove all the plate, and we have this big hole, and we have to deal with the remaining deformity, and we have to plan to descend with or without osteotomy. Usually, probably we need to descend without osteotomy. Like these cases, you need to remove the hardware in the right hip. We can use it 2 times. What's difficult, and use a distal supracondylar osteotomy, and in the left one, we remove it in 1 time easily and use the bending part of the femur to do an osteotomy, a subtrochanteric osteotomy, to descend and put the hips in place. The take-home messages: DDH is still common in our countries. It's always difficult to treat it. The later open reduction and osteotomy can work, but if you have a bad treatment, could be the worst case scenario. We have 3 scenarios with different approaches, and you have to select implants according to the plan. Nowadays, in total hip arthroplasty, we have for sure better outcomes, and it's quite similar to the adults. Thank you so much.
Thank you, doctors, for this excellent presentation. So please welcome to the podium. Please, Dr. Sacha. Now it's time to discussion and question, please. Question can be online too. So we will other question. I have some question to Dr. Miquel. Doctor, we know the difficult to placement insert acetabular. So, do you have some tricks for placing the insert and the femoral head?
Well, it's the most important part of the surgery, I think, when you have to insert the insert, no? So what I always recommend is to be very careful. You must be able to see all the rim of the cap. And when you insert the ceramic, there are some devices, but I prefer to do it with my fingers, to be very, very careful, to be very, very slow, to do very slowly. And when I am sure that it is really well positioned, this is the time to impact only with the hammer only once. So I think that this is very important, to see perfectly all the rim. Another point that I think it's interesting, but for when you use ceramic femoral heads, is to clean very, very well the trinion of the stem, because if there is no very well clean, it's another risk factor for fracture of the head.
Thank you, doctor. Dr. Sacha, please. Respect to this patient with haemophilic, in the postoperatory immediate, do you have a change respect to rehabilitation? Do you have immediately, or do you?
The post-op for this kind of patient is exactly the same like a primary for any other condition. Like I say, the people who deal with the disease is going to tell you use this medication, don't use this anti-inflammatory, but all the rest is exactly the same like a primary. We're doing 2 and sometimes 3 surgeries at the same time. But these are young patients with not bad muscles, and we go straight forward for the rehabilitation.
Well, Dr. Erwin, respect to patients with juvenile arthritis, we know the difficult on the evolution of these patients. In this respect, do you prefer to, in this patient collocation of the COP double mobility or COP primary?
In that time, we don't have a great system like it's a dual mobility. In that moment, we use the femoral head size 32. And the problem with that kind of patients is all the muscles very weak. And in that moment, the evaluation, all the subjects was from the good results for the obtain well ranks of motions.
Thank you, Doctor. Anyone question? Please, Doctor.
Buenos días. Primero quiero disculparme por mi mal inglés, así es que
I apologize for my English, so I'm going to ask in Spanish. Miguel, you talk about very young patients. Is there a consensus on the age? Because Sacha made my day happy when he mentioned young patients of less than 65 years of age. Very happy. So at what age do you consider a young patient?
Let me translate. The question is, what is the age that Dr. Pons consider for using ceramic on ceramic? Is that the question?
Sí, más o menos.
In my opinion, I use ceramic on ceramic for patients younger than 55 years. I think that after 55 years, the literature show that the follow-up of the patient with cross-linked polyethylene with ceramic is so long that we don't need in this patient ceramic on ceramic. So my age is about 55 years old.
¿Y alguna razón en especial para esa edad? Por la gran movilidad que
Any
tienen?
reason for that age? Because of their good mobility. I don't know if your country, but there's a lot of difficulty in my country to use ceramic on ceramic. It's like a mantra, crackling and fracture. And I have only seen 2 fractures. So what do you consider is the reason why the community does not adopt young patients for ceramic on ceramic and tend to go for new systems like dual mobility?
The question is why orthopedic community or hip and knee surgeon don't use more ceramic on ceramic on the young patients, and they probably prefer any other combination of variant.
Well, I think that there are some reasons, no? But honestly, I think that the main reason is because ceramic on ceramic is an European invention. That means most of the literature is American literature, no? So ceramic on ceramic is something described in Europe. And I think that for American people and then for the rest of the world to accept a European invention is sometimes very hard, no? For example, we have the cementing technique, it's an European, hydroxyapatite, double mobility has been very difficult to accept. And of course, the ceramic on ceramic. I think that the first results with the old ceramics, it was true. There was many cases with fracture. But with the new devices, the Delta ceramic, the rate of breakage, it's very few. I knew that the follow-up is very long with the cross-link and ceramic devices, no? But up to 15 or 20 years. But what will happen in patients younger than 30 or 35 or 40 years, no? I think that these patients, the wear of the wear is meaner with ceramics on ceramic, so that's my election. Another reason is the price. Of course, ceramic on ceramic is more expensive than ceramic on poly.
Pero a la larga es más
Dr.
barato.
Sacha has a
To tell you the truth, I think the best tribology for young patient, especially if they are a normal anatomy with degenerative changes, is the metal resurfacing hip. I did for a long time. We're not allowed to do that because North American regulation to my country and say, we're not going to send you this anymore. But at my age, because I'm younger still, I like to have done a resurfacing hip who the patient are straightforward doing everything. They flex and stand and do sports. And a lot of sports and a lot of jobs who I'm not sure if I'm going to allow for a patient with the ceramic on ceramic.
There's a question from the audience, and it's regarding the same topic. It's what type of sports you allow to young patients and why? This is a question for all of you.
I don't think it's important what we think about this, but it's a very good report for the University of Virginia, I think. This was a long time ago, but it's real. The amount of sports who you allow the patient with the ceramic on ceramic, and these are reduced to 70% of any kind of sport. And in metal was around 80 or 90%. You don't feel confident to say to somebody, throw to somewhere or use a bike. And no, with the ceramic on ceramic, I think you're agree.
Una
¿Tiene
pregunta
otra
para
cuestión?
Sasha. Tú dices el riesgo de infección en un paciente
You talk about the risk of infection on a patient with hemophilia. You say it's high.
cambias el esquema.
Do you change the antibiotic prophylaxis regimen to an antibiotic treatment, or do you maintain the treatment 5 or 10 days?
Regarding the risk of infection that is higher in the hemophilic patient, the question is regarding the prophylaxis with antibiotics. Do you do a standard prophylaxis in those patients?
Yes, indeed. We normally use for a primary total hip or total knee, just one single shot of antibiotic on the anesthesia induction. For this kind of patient, as well as a rheumatoid, a bad rheumatoid, we use 48 hours or 2 days of antibiotic, no longer than that.
There's a question from the audience, from the international audience. So if you have a patient with that has the 4 joints, 2 hips and 2 knee compromised, what is the order of your surgery?
The older?
Which one do you perform first, second, the order?
We always do hips first because I'm a hip and a knee surgeon. I don't like to talk about hips, but I think the academy is in the knee. But we start with the hip total and then do the knee. If it's a bilateral hip or bilateral knee, it doesn't matter for us because we use posterior approach and we need to move the patient for hips, and that's very, very non-funny. But for knee, like showing one of the pictures, we did few times, 2 teams doing exactly the same, but it's better to do one and following the second one.
Okay, there's another question, Dr. Paulo.
Dr. Pons, one question. The squeaking is the more in the young people or the same to the old people?
Well, I really don't
ratio?
know, no? And I don't know if the literature says something like that, no? But if you read literature, the rate of squeaking is very different according to the paper you read. There are some reports about less than 0.5% until reports about 35% of the patients, no? So I think that many times the squeaking or the noises are more related about the way that the doctor asks to the patients than really what the patient feels, no? I mean, if you have a patient and you ask many times, are you sure you don't hear any noise on your hip? Are you really sure? So I think maybe this patient will listen to this noise, no? On the other side, it's true. There is some patient with a squeaking that you can listen even when the patient comes into your office, and it's true. I don't know. I can't tell you if it's more frequent in younger than in older. I am sorry.
Any other question from the audience? No. You want to do a closing remarks, Nicole? Yes. So.
Well, thank you so much. Thank you, Vicas. I don't know if you are here. Thank you, Sofian, to join for all the word, the SICOT word about Pioneer, this conjoined meeting, and thank you for joining us. I don't know if Vicas have a final remark.
No, he left already.
Well, thank you so much.
Esperando los aplausos. No nos bajamos. Digo.
Thank you very much, everyone.
Buenos días. Primero, muchas gracias a ustedes por estar hoy acá a esta hora.
Good morning.